Good afternoon. Today we're going to discuss myocarditis and other pericardial diseases such as pericarditis and endocarditis, infective and non-infective. Let's talk about myocarditis first. What is myocarditis? It's basically an inflammatory disease of the myocardium with a wide range of clinical presentations from very mild to devastating. Can be a result of systemic disorders as well as viral infections. The viral infections most commonly present are ecovirus, influenza, parainfluenza, Epstein-Barr, and HIV. Myocarditis is probably caused by not only infectious organisms, even though it's the most common, but also autoimmune disorders and other exogenous agents. In addition, genetic and environmental predisposition could also produce this. Bacterial infection, any cytotoxic effect of a medication, any cytokine expression by tumor necrosis factor in a major inflammatory reaction, and myocarditis is frequently associated with pericarditis. Most cases are presumed to be caused by a common pathway of host-mediated autoimmune-mediated injury. Although direct cytotoxic effect of the causative agent and damages due to cytokine expression in the myocardium may play some role in myocardial etiology, virals are one of the most common. In viral myocarditis, viral infections usually are Coxsackie, as I said, they're self-limited. They could produce from a mild to a very high mortality rate. Viral replication may lead to disruption of metabolism and inflammation of the myocardium. Vasospasm could be induced by endothelial cell due to viral infection. New evidence also has proven that dystrophin disruption by expression of other enteroviruses, such as parvovirus, could produce depositions of immune complexes contributing to diastolic dysfunction. Myocarditis could also be produced by idiopathic. Basically, the cause is unknown. A viral etiology, anyways, is often suspected but unproved. So again, the most common viruses are Coxsackie virus, enterovirus, influenza, cytomegalovirus, Epstein-Barr virus, even hepatitis, rubiola, varicella, arbovirus, rickettsia. In bacterial infection, diphtheria, TB, streptococci, meningococci, clostridium. Fungal infections are also caused. For example, candidiasis, aspergillus, histoplasmosis, coccidioidomycosis. Drugs usually cause hypersensitivity myocarditis, including chemotherapy drugs such as streptomycin, cyclophosphamide, immunomodulators, doxorubicin. Antibiotics that could also produce this include penicillin, chloramphenicol, sulfa drugs. Antihypertensive that could produce myocarditis, even though it's not in your PowerPoint, methyl dopa, spironolactone, anti-seizure medications such as phenytoin and Tegretol, amphetamines, cocaine, catecholamines, and many other systemic inflammatory diseases such as rheumatoid arthritis, sarcoidosis, Kawasaki, Crohn's disease, lupus, ulcerative colitis, Wegener's granulomatosis, thyrotoxicosis, scleroderma. So there are many, many causes of myocarditis, even though viral infections are the most common. The clinical presentation of myocarditis basically as an inflammation is most commonly associated with fever, signs and symptoms of infection such as tachycardia, but this tachycardia is out of proportion to fever. Um, Patients could also complain of chest pain uh, with concurrent pericarditis, night sweats, chills, dyspnea. In viral myocarditis, um, flu-like symptoms prior to the illness, like for 2 weeks or 1 week before, is a relevant history associated with fever, arthralgias, malaise, or pharyngitis, or tonsillitis, or any type of upper respiratory tract infection. In addition, patients could complain of palpitations, syncope. Maybe the only presentation could be a sudden cardiac death due to underlying ventricular arrhythmias. Or also patients could come with signs and symptoms of heart failure in severe cases. EKG is a non-specific, but most likely is associated with a widespread um, of ST elevation or depression, so it's not as specific as pericarditis. Um, Most commonly, it presents with an AV block with prolonged QRS or ST elevation, such as in pericarditis. So the changes for the EKG myocarditis are not specific um, as for ST elevation myocardial infarction or as with pericarditis itself. Chest x-ray usually is completely normal because the myocardium, the actual heart muscle, is affected. Cardiac enzymes, including troponin I and CKMB, are elevated. Echocardiogram is basically done to exclude other causes of heart failure. Um, you could also do cardiac angiography to rule out coronary ischemia as a cause of a new onset of heart failure. Laboratory testing for myocarditis basically include a CBC, erythrosedimentation rate, which most of the time is elevated, associated with C-reactive protein, also elevated. You will be doing rheumatology screening to rule out the actual etiology of the disease in hypersensitivity cases. Um, You could also do serum viral antibody titers for the most common virus as etiology of the disease. You could also do a biopsy. Differential diagnosis include basically due to the EKG changes, um, an systemic elevation, myocardial infarction, as well as due to the actual inflammatory reactions and presence of uh, WBC elevated in CBC and cell rate and CRP, sepsis. Treatment for the disease itself is supportive because, again, most of the time this disease is associated with viral infections, um, but blood cultures could be completely positive when the actual cause is bacterial infection. In addition, pharmacotherapy includes antibiotic, of course, when the cause is associated with bacterial infection, and we'll cover this under endocarditis because they're exactly the same antibiotic therapy. Um, in addition to that, vasodilators could be used for the management of myocarditis, such as nitroglycerin or sodium nitroprusside, When the myocarditis is associated with high blood pressure, in addition, angiotensin converting enzyme inhibitors such as enalapril and diuretic use if the presentation is CHF exacerbation. Anticoagulation may be advised as a preventive measure and in other causes of heart failure, although no definitive evidence is available. Antiarrhythmics, class 3, could be used when the disease process is associated with supraventricular arrhythmias. In addition, you could use beta blockers as well. Inotropic drugs, once the ejection fraction is diminished due to associated CHF with myocarditis, such as dobutamine, milridone, may be necessary for severe decompensation. In addition, non-pharmacological therapy, hemodynamic and cardiac monitoring, oxygenation, and fluid management when we are not in the presence of volume overload in CHF. Watch all the time for signs and symptoms of progressive heart failure. Sometimes when the patient presents with a complete heart block, transvenous spacing is necessary, as well as in extreme cases, cardiac transplantation and ventricular assisted device, or percutaneous circulatory support, such as LVAD or extracorporeal membrane oxygenation is needed. Now let's talk about pericarditis. Pericarditis is no more than an inflammation of the pericardium, often with fluid accumulation. Remember that the pericardium has two layers, the parietal and the visceral pericardium, and basically these two layers surround the heart. Normally the pericardial space contains up to 50 mLs of fluid, and it's necessary for nutrition as well as to prevent damage or friction. Pericarditis may be caused by many disorders such as infection, viral and bacterial infection, as well as fungal. Trauma could produce pericarditis, tumors, malignancy, metabolic disorders, connective tissue disorders, drugs, uremia, myxedema, myocardial infarction, etc. We're going to go through all the etiologies in a minute. But it could also be completely idiopathic. Remember that again, pericardium has two layers, and the sac is basically created to limit distension of the cardiac chambers, nutrition, and to avoid friction. The pericardium is richly innervated by the sympathetic and somatic efferent nerves. Any stretching would stimulate mechanoreceptors that produces some changes in cardiac volume and tension. And those are responsible for transmitting the pericardial pain that patient would feel with pericarditis. Remember that this is, besides starting as visceral pain, most likely and most commonly is associated with parietal pain because it's sharp and is associated with movement and breathing patterns. The phrenic nerve is responsible and very vulnerable for injury during surgery of the pericardium, producing traumatic or post-MI, which is called Dressler pericarditis, that we're also going to discuss in a minute. Acute pericarditis develops quickly, causing an inflammation reaction. It could be subacute, when it occurs within weeks to months of an incident or event, or it could be chronic after 6 months, and that symptoms, the symptoms of chronic develop very slowly. Their prominent feature, although the symptoms that we're going to discuss right now, is effusion, most likely present or seen in a chest x-ray and an echocardiogram. In addition, patients could present with a sudden or gradual onset of sharp or stabbing pain with radiation to the back and neck or to the left shoulder or arm. It is more severe when laying supine and is relieved with sitting. Also has variations with respiration, is worse with inspiration and relieved by expiration. Radiation also to the trapezius could be present. Other symptoms that are associated with pericarditis could include low-grade fever because it's an inflammation, shortness of breath, as well as dysphagia. Patients could also have, upon auscultation, a friction rub because remember, the pericardial fluid is present to avoid friction. When it's not present, you will be able to hear the actual rubbing effect. Before we go into the diagnosis, let's review again the possible causes. Again, it could be completely idiopathic, most commonly associated with viral infection, and these viral infections, the same as myocarditis, could include Coxsackie virus, echovirus, influenza virus, HIV. So all these patients must be tested for HIV as well. Bacterial infection associated with streptococci, staphylococci, Haemophilus influenza, fungal infections such as histoplasmosis, coccidiomacosis, candidiasis, parasites. So if we're going to continue going through the causes, are more or less exactly the same causes as myocarditis: autoimmune, rheumatoid arthritis, lupus, scleroderma, cancer, leukemia, chemotherapy itself, radiation therapy, inflammatory disorders besides the autoimmune, such as inflammatory bowel diseases, sarcoidosis, amyloidosis. Acute pericarditis again is associated with pericardial effusion, which again is no more than an accumulation of fluid in the pericardial layer. The fluid could be serous, could be serosanguinous, it could be pus or a chylothorax. It's exactly the same as pleural effusion. And when you do pericardiocentesis and you send the fluid to analyze, the criteria is more or less the same as effusion as you would see in 668. Pericarditis could also be caused by constrictive pericarditis, which is very uncommon and result from marked inflammatory fibrotic thickening of the pericardium. This fibrotic tissue basically or most likely contains calcium deposit, and the pericardium has an impairment for ventricular filling, decrease in stroke volume and cardiac output. These diseases could include liver scarring, cirrhosis of the liver. Now, let's talk about diagnosis. How do you diagnose pericarditis? EKG, what you basically see is a widespread elevation of the ST segment, but is more pathognomonic when it's present in lead 1, V5, and V6, with a PR depression in lead 2, AVF, V4, and V6. There are other patterns that could be present, but again, the most common presentation is the widespread elevation of the ST segment, which is completely impossible to have myocardial infarction in all the leads. Another form of presentation could be inverted T waves in leads with previous ST elevation, so it produces an alternating and then returns to normal EKG baseline. Most commonly, the T wave ratio is more than 0.25, and this is most likely present in acute pericarditis. But again, what is most commonly seen as pattern is a widespread elevation of the ST segments. Echocardiography is done to check for effusion, particularly loculated effusion with localized tamponade or not, which because of its atypical manifestations may not be suspected and which may be suggested by indirect findings such as compression of the chambers and characteristics variations of the heart rate with respirations. Cardiac filling abnormalities and wall motion abnormalities can also be seen through the echocardiogram. Again, concentrate on the EKG in acute pericarditis, which may show abnormalities confined to the ST segment and T wave, usually in most leads. But again, the ST segment in 2 or 3 of the standard leads become elevated but subsequently return to baseline, which it doesn't happen in myocardial infarction. Unlike myocardial infarction, acute pericarditis does not cause reciprocal depression in ST segments. So you will not see those reciprocal changes. And they're not pathological Q waves, which could be present in myocardial infarction. The PR segment may be depressed, and after several days or longer, T waves may become flattened and then inverted through the EKG. Chest X-ray usually is normal, but it could help when the patient has a large pericardial effusion. Other tests that could be done basically could be a CVC. Of course, the patient is going to have leukocytosis, BON and creatinine in case of the presence of acute kidney injury and uremia, because uremia is another cause of pericarditis. You could do serology for streptococci, virology. You could do collagen panel for excluding lupus and rheumatoid arthritis, such as ANA and anti-DNA antibodies, thyroid function for thyrotoxicosis and hypothyroidism, which is another cause. Sed rate will be elevated, and cardiac enzymes should not be elevated in the presence of pericarditis, because remember, it's an outside layer of the heart. The myocardium is not involved. So, how do we treat pericarditis? Pericarditis, remember that most commonly is idiopathic or presumed to be the most common etiology as viral. So the most common treatment for pericarditis will be an anti-inflammatory for 1 to 3 weeks. This includes NSAIDs or corticosteroids for pain and inflammation. So you could give, for example, colchicine or any type of NSAID. You could treat the underlying cause if it's diagnosed. If the patient has any type of complication, such as large pericardial effusion, signs and symptoms of a tamponade, possible myocarditis as complication, the patient should be hospitalized. Hospitalization is warranted for patients with an initial episode of acute pericarditis, particularly those with moderate or large pericardial effusion. Any elevated temperature, immunosuppression, any recent trauma, any patient with oral anticoagulation therapy with pericarditis, because they might bleed more and develop a tamponade quicker. Hospitalization is also needed to determine etiology and to observe for the development of cardiac tamponade. Remember that. Pericarditis could evolve and get complicated with cardiac tamponade. And basically what happens is that there's pressure in the pericardial sac that exceeds normal feeling pressure, and that would not only restrict the right ventricle and feeling of blood return from the pulmonary bed, but also would restrict cardiac output. Etiology of cardiac tamponade could include the actual pericarditis and exactly the same causes that developed pericarditis and myocarditis. If you follow, it's basically more or less the same: malignancy, uremia. If the patient is on anticoagulation therapy and is bleeding, it could bleed into the pericardial sac and develop a cardiac tamponade. Chronic pericarditis, myocarditis, lupus, myxedema, etc. Patients basically present with more or less the same symptoms, in addition to muffled heart sounds, hypotension, and jugular vein distension, which is a triad. Patients have pulsus paradoxus, which is no more than a decreased during inspiration, narrow pulse pressure, as well as shortness of breath, pitting edema, ascites. If we're going to do an electrocardiogram, you would see that there's low voltage. And as well, which is pathognomonic of tamponade, electrical alternance on the EKG suggests cardiac tamponade, which is no more than a change of QRS complex, wandering in amplitude, most commonly in lead 2. But also could indicate severe pericardial effusion and not necessarily cardiac tamponade. When tamponade is suspected, echocardiography is done unless even a brief delay might be life-threatening. Then we should avoid echocardiogram, and pericardiocentesis should be done immediately for diagnosis as well as for treatment. Remember that cardiac tamponade is a clinical diagnosis. Even though echocardiogram helps, echocardiogram findings alone are not an indication for pericardiocentesis. Again, EKG with low voltage QRS and ST elevation and PR depression. Electrical alternance is a classic finding. Remember that. Chest X-ray could be completely normal or could show an enlarged cardiac silhouette indicating that there's pericardial effusion. And even though an echocardiogram is the modality of choice for diagnosis, it's not an indication alone for pericardiocentesis. You also have to look at the clinical signs and symptoms of the patient. Now, how do we treat cardiac tamponade? Basically, since the patient has decreased venous return from the pulmonary bed and decreased cardiac output, you need to, while you prepare the patient for pericardiocentesis emergently, IV fluids. You have to be able to improve cardiac output and right ventricular filling, as well as hemodynamics with IV fluids. Pericardiocentesis, again, if you don't have the echocardiogram and it's a life-threatening situation, you should do pericardiocentesis for diagnosis as well as for treatment. Except in emergency, pericardiocentesis is a potential lethal procedure and should be done using echocardiography guidance. It could also be done as during cardiac catheterization, and the patient must be sedated with morphine or fentanyl and midazolam, so conscious sedation is usually necessary. For clinical procedures, students, DNP, basically the procedure is done with a 16 gauge needle that is attached via a 3-way stopcock to a 30 to 50 ml syringe. The pericardial is entered via the right or the left xyphocostal angle, or from the tip of the xiphoid process with the needle directly inward and upward and close to the chest. The needle is then advanced with constant suction applied to the syringe. Echocardiography again may be used to guide the needle as agitated saline is injected through it. Agitated saline contains microbubbles, facilitating its identification by contrast during echocardiography. Once the needle is in place, the needle should be clamped next to the skin to prevent it from entering further than necessary and possibly puncturing the heart. EKG monitoring is also essential during the procedure to be able to detect arrhythmias. Fluid is then withdrawn until intrapericardial pressure falls below the right atrial pressure. And that's basically a brief explanation of the procedure. Patients should be admitted to the ICU and monitored for hemodynamics. Let's talk about constrictive pericarditis, even though I basically touched it a little bit before. Remember that is uncommon and result from marked inflammatory fibrotic thickening of the pericardium and loss of elasticity interfering with diastolic filling. Causes of constrictive pericarditis, in addition to cirrhosis of the liver, pericardiotomy, intrapericardial hemorrhage, uremic, more or less the same causes as acute pericarditis. Is less common. Constrictive pericarditis mimics restrictive cardiomyopathy, and remember the autoimmune diseases that could produce it, like scleroderma, CHF, dyspnea on exertion. Patients have very high degree of decreased exercise tolerance. In addition, patients could complain of chest pain, orthopnea, or paroxysmal nocturnal dyspnea, even though they're uncommon. This is more commonly present in CHF exacerbation. Remember that venous return from the pulmonary bed is compromised, so patients tend to have more of the right ventricular heart failure signs, such as peripheral edema, hepatomegaly, ascites, jugular vein distension, and cosmal respiration. There is also pericardial knock, heard most commonly at the level of the apex. EKG is not very helpful for constrictive pericarditis because since the pericardium is fibrotic, what basically shows is decreased voltage and inverted T waves. So most likely you're going to have the presentation in examinations of acute pericarditis with a widespread ST elevation. Chest X-ray, even though it's not helpful, it could show calcifications, and you could see other symptoms such as pulmonary fibrosis, for example, due to underlying pathology. Echocardiogram should be done, as well as CT of the chest and CT of the heart, to be able to see the fibrotic tissue. Differential diagnosis, acute as well as myocarditis, um, and any disease process that could decrease the cardiac performance, such as sepsis, because they have exactly the same set rate, elevated CRP, WBC, elevated. Diagnosis most of the time is suspected based on echocardiography, but cardiac catheterization and CT are usually required. Because ventricular filling is restricted, ventricular pressure tracing shows a sudden dip followed by a plateau in early diastole. Rarely, right heart biopsy is needed to exclude restrictive cardiomyopathy, even though it could be done. Again, EKG changes are non-specific, usually with a low voltage QRS, and T waves are usually non-specifically abnormal. Atrial fibrillation occurs in about 1/3 of patients with um, constrictive pericarditis. And again, chest x-ray with peripheral calcification and other signs of the underlying disease. The changes on echocardiography, non-specific as well. When the right and the left ventricular filling pressure are equally elevated, Doppler echocardiography helps to distinguish constrictive pericarditis versus restrictive cardiomyopathy. So Doppler echo is one of the best modalities to differentiate both illnesses. CT and MRI can identify pericardial thickening, such as fibrotic tissue that is present, and also helps to differentiate restrictive cardiomyopathy from constrictive pericarditis. Cardiac MRI enhancement with gadolinium helps also identify the constriction and the fibrosis. Treatment for constrictive pericarditis, again, due to the associated illnesses or etiology, is treating the underlying etiology. Many patients that are symptomatic require admission and pericardiectomy, so basically laser the fibrotic tissue through surgery. Now let's try to differentiate, and we're going to go over endocarditis now. Endocarditis versus pericarditis. Remember that pericarditis, it's an inflammation of the pericardium. Okay, it's the outside layer of the heart. Even though it could be produced by bacterial infection, the main pathophysiology is not an infectious process of the endothelium of the heart. It's the pericardium. Even though pericarditis could have pericardial friction rub and patients could have underlying valvulopathies, a new murmur that is heard on a patient that is being known from the past that there is no associated valvulopathy and fever of a non-origin is a hallmark for suspicious of endocarditis. So remember that. Any new murmur that is heard on a patient should raise the suspicions of endocarditis. Now let's talk about endocarditis causes. And we're going to go over as well as endocarditis, infectious and non-infectious. Common disease process that produced endocarditis is infection. Patients that have a non-valvular heart disease, the prior etiology most commonly producing this is rheumatic fever. Any recent dental surgery, any GU instrumentation, any respiratory surgery or heart disease congenital, any prolonged use of any central line, burn victims, or hemodialysis with catheter. It's actually one of the sources of entrance of the infection. Even though pericarditis, again, it could be infectious process, this is in the pericardium, it's not in the endothelium. And we already went through the rest of the causes. Now, endocarditis usually refers to infection of the endocardium. The term can also include non-infective endocarditis, in which sterile platelets and fibrin thrombi form on cardiac valves and adjacent to the endocardium. Sometimes this leads to infective endocarditis, but the original source was completely sterile and thrombi formation. This basically impairs the cardiac function, and usually bacteria are the one who produce endocarditis versus viral in pericarditis. Streptococci or staphylococci or fungi is present in endocarditis. The normal heart is relatively resistant to infection. Bacteria, fungi do not easily adhere to the endothelium surface, and constant blood flow helps prevent them from setting on endocardiac structure. Two main factors are required for endocarditis to be produced: a predisposition abnormality of the endocardium and microorganisms in the bloodstream, which is bacteremia. So patient must have a source of entrance of bacteria infection. Predisposing factors, again, congenital heart disease, rheumatic valvular heart disease, bicuspid or hypertrophic cardiomyopathy, any prior endocarditis, any prosthetic valve. So look for those predisposing causes in the history of the patient as well as in your exam. Any thrombi, any ventricular septal defect, congenital, any vegetation. Microorganisms that infect the endocardium may originate also from distant infected sites, such as patients that have infected gums, any sepsis from UTI, any cutaneous abscess, any venous catheter, any peritoneal shunt, any prosthetic device, gingivitis. Even though toothbrushing and chewing can cause bacteremia, usually due by virulent streptococci in patients with gingivitis. Causative microorganisms vary from site to site, but overall, streptococci and staphylococci aureus cause 80 to 90% of cases of endocarditis. From those, the most common is Streptococci viridans. Let's talk a little bit about the pathophysiology before we go into the signs and symptoms. Basically, after colonizing, the bacteria, vegetations, microorganisms are covered by a layer of fibrin and platelets which prevent access by neutrophils, immunoglobulins, and complement. Endocarditis has local and systemic consequences. Local include, for example, formation of an abscess and tissue destruction, valvular regurgitation, aortitis. Systemic consequences, patients could develop embolizations, pulmonary emboli, septic emboli, infarctions, pneumonia. They could have complications with kidneys and spleen and diffuse glomerulonephritis, etc. As I previously said, endocarditis could be infectious or non-infectious. Signs and symptoms. Patients with pericarditis, we already went over the signs and symptoms. Patients could have localized, sharp, well-localized retrosternal pericardial chest pain. This is a parietal pain that varies with inspiration and recumbent position, relieved by sitting forward, associated with shortness of breath. Endocarditis, you will see the major and the minor criteria, but most commonly is associated with fever, malaise, night sweat, weight loss, and general sickness. We're going to go through the criteria of the symptoms in a minute. Initially, symptoms are vague, such as low-grade fever, night sweats, fatigability, malaise, and weight loss. Chills and arthralgias may occur. Symptoms and signs of valvular insufficiency may be the first clue. Initially, less than 50% or 20% of the patient have fever or a murmur, but eventually almost all develop both fever and murmur. Physical examination may be normal, but it could include pallor, fever, change in a pattern as well of a pre-existing murmur. So a new murmur or a change in pattern of a pre-existing murmur. Tachycardia could also be present. Patients could come for the first time very toxic with septic shock or with right-sided endocarditis such as pulmonary emboli that may cause cough, tachypnea, pleuritic chest pain, hemoptysis, and a murmur of tricuspid regurg has to be present if it's right-sided. Physical signs and symptoms. This is going to be the explanation of the criteria. And we already went over pericarditis, that patients could have pericardial friction rub, fever, pleural friction rub as well. Now, let's talk about the criteria of pericarditis. Okay. We have major criteria and minor criteria. The major criteria says, and you have to know this, that 2 positive blood cultures for organisms or 3 positive blood culture for our organisms shows evidence of endocarditis. So infective endocarditis is definitive when the actual microorganisms could be isolated or endocardial vegetations could be seen in an echocardiogram. These 2 criteria has a very high sensitivity and high specificity, more than 90%. So how do we diagnose endocarditis? The 2 criteria says that for definitive clinical diagnosis, 2 major criteria or 1 major criteria and 3 minor criteria or 5 minor criteria should be present in order to diagnose endocarditis. So for definitive clinical diagnosis, the following should be present. 1, 2 major criteria, 2, 1 major criteria and 3 minor criteria, or 3, 5 minor criteria. And what are the major criteria? Remember, 2 major criteria should be present. Major criteria are either 2 positive blood cultures or 3 positive blood cultures or serology evidence of Coxiella burnetteli on one of the positive blood cultures, or an echocardiography with evidence of either an oscillating intracardiac mass on a heart valve or an implantable material with that oscillating mass, the presence of a cardiac abscess, a new dehiscence of a prosthetic valve, or a new valvular regurgitation murmur, or seen by an echocardiogram. So if you have 2 of those major criteria, you have endocarditis. Or if you have 1 major and 3 minors, which minors are IV drug abuse, fever, notice that fever is not a major criteria, so fever more than 38 centigrade, or any vascular or immunological phenomena. Vascular phenomena that you see the presence of an arterial embolism, so a patient that comes with a pulmonary emboli, or septic emboli, or myocardic aneurysm, or intracranial hemorrhage, or conjunctival petechia, or the presence of non-painful indurated lesions in the phalanges, which are called Janeway lesions, or any immunological phenomena such as glomerulonephritis or painful nodules such as Oschler nodes or Roth spots, or the presence of positive rheumatoid factor. Microbiology evidence of infection consistent with but not meeting any major criteria. Any serological evidence of infection such as SER rate or CRP, those are minor criteria. So if you have a 1 major and 3 minors, or you have 5 minors, or if you have 2 majors, those are the definitive diagnosis of endocarditis. Laboratory evidence, we discussed already the pericarditis, so we're not going to lose time on that. But an endocarditis, of course, you're going to have left shift. Remember that the presence of bands with an elevated WBC. We went already through the major criteria, what's present on the echocardiogram and the TEE. Positive blood cultures and positive serological evidence of infection such as SED-RED elevated or CRP. Now, remember that in pericarditis, NSAIDs, colchicine or ibuprofen, or corticosteroids such as dexamethasone and prednisone, antibiotic therapy, the same antibiotics such as in endocarditis, if bacteria is present. And of course, and more important, you have to monitor for signs and symptoms of tamponade. Endocarditis, and the guideline will be posted, but remember that if we go through the guideline in class, the most common antibiotics used for endocarditis, and this more or less applies to the majority of the etiologies, most commonly is treated with penicillin G or ceftriaxone. So even though in your PowerPoint the empiric treatment says penicillin G with gentamicin, that could be one choice. So penicillin G with gentamicin, or you could also use penicillin G with vancomycin, or you could use ceftriaxone instead, 2 grams in 24 hours with 1 dose only, with or without gentamicin or vancomycin. So those are the most common antibiotic used for the majority of the bacterial etiology. If we review the treatment in the guideline for streptococci bovis, for example, is again penicillin G or ceftriaxone plus gentamicin and vancomycin. If we review in the guideline the streptococci viridans, is the same, penicillin G or ceftriaxone plus gentamicin and vancomycin. Now, if you open the guideline and we review streptococci bovis, same thing, penicillin G or ceftriaxone with or without gentamicin and vancomycin. But you could also give aqueous penicillin sodium with the same combinations. In addition to that, if the patient has staphylococci, in the absence of prosthetic valves, You could use nafcillin or oxacillin with gentamicin, or you could do cefazolin with gentamicin or vancomycin. Now, with prosthetic valve, you could use, for example, nafcillin plus rifampin plus genta, or you could do oxacillin with vancomycin, rifampin, and gentamicin. As you could see, when you have a prosthetic valve, you need a higher coverage and 3 combination: nafcillin or oxacillin plus rifampin plus gentamicin, or oxacillin plus vanco plus rifampin plus gentamicin. So you need a better coverage with staphylococci. And the rest is more or less the same. Um, for example, if the patient has enterococci, the variation is here ampicillin plus genta. If the patient is completely allergic to penicillin, you could do vanco plus genta. In addition to that, with penicillin resistance or sensitivity, you could use, for example, Cyvox, um, or you could use imipenem, um, even though it's a beta-lactam. Other combinations, you could use Cipro, but the Cipro has to be combined with Vanco and gentamicin. You could also do doxycycline plus gentamicin. Those are the possible combinations when the patient is allergic to penicillin. Now, let's review in the guideline about infective endocarditis and how should we prevent the spread, and how do you basically treat these patients, follow up, as well as how do you prevent or give prophylaxis to patients that are going through any procedure or any dental care. So patients that have oral cavities, skin, open respiratory catheters, GI, prosthetic valves, pacemaker, IV drug abusers, bacteremia. Again, this is basically reviewing the etiologies, that an injury, a thrombi, could produce this. This or the signs and symptoms that we already went over. Now, after this PowerPoint, I'm going to open the guideline and walk you through the guideline and basically touch outpatient therapy and follow-up and prophylaxis as well. So let's go and do some questions before. Which of the following is not useful in cardiac tamponade? Remember that in cardiac tamponade, you need to improve hemodynamics. So the first and best choice is to give IV fluids. It doesn't matter that a patient has signs and symptoms of overload. If the patient has pericardiac tamponade, your first approach is to improve cardiac output and hemodynamics by giving IV fluids. Then secondly, pericardiocentesis stat. You could do a Doppler ultrasound or echocardiography to diagnose and treat and guide pericardiocentesis. You could do an EKG, but what you cannot ever do is give diuretic therapy because you are preventing preload, and that's exactly what you need. You need a high preload and high venous return to improve hemodynamics and cardiac output. Question number 2, which of the following is not found on the EKG of acute pericarditis? Is D, because remember electrical alternance is the variation in lead 2 of QRS complex, and that is pathognomonic of tamponade. You could have a widespread elevation of the ST Normal EKG that could be present, inverted T wave could be present, but electrical alternance is pathognomonic of tamponade, which is not a sign and symptoms of acute pericarditis, and it would be B because remember oscillar notes or the painful notes that are present as minor criteria in endocarditis, which is not one of the four types of cardiomyopathy. We had already a presentation on that. Remember that you have hypertrophic, restrictive, you have dilated, and you even have a dysrhythmic that we did not cover, but there's no infective cardiomyopathy. That is endocarditis. And this is the end of this presentation. So now we're going to go over the guideline for treatment.